simultaneously. So we are currently live on Facebook and we're letting the room populate for a few minutes before we get started. To those of you joining on Facebook, we will be starting the program momentarily. Okay. The participants are joining. Welcome, everybody. We're going to begin in just a few minutes. I see we already have a question in chat. Greetings right back to you, David. Thank you for joining. Get all my screens up here. We'll give everybody just a few minutes and we'll start at about 6:02 your time, 9:02 our time. Always fun. Okay. So we have people keep joining. It's, heart month, so I can use my heart mug today. Okay. We'll be getting started in another 30 seconds. The song's in my head, guys. It won't go away. What's that about? Hello, Joseph on Facebook. Hello, Kathy on Facebook. Hello, Anna on Facebook. I feel like Romper Room. Remember that? Okay, most of you won't remember Romper Room. Okay. All righty. We are kicking up those attendance numbers and people are going to continue to join as we get started. So I will start with the boring housekeeping before we get going tonight in earnest. So number one, welcome to the Hypertrophic Cardiomyopathy Association's Bighearted Warrior Tour. Tonight is February 11th, 2021. We are streaming live on Facebook and we are live in our Zoom webinar. The link to the webinar is available through Facebook. We will not be taking questions from the Facebook community tonight. If you want to ask questions, please join us in the Zoom room. You can register right online there as you go in. So there's no need for pre-registration. You got the link. So I hope that you come in and join us. We are going to be streaming tonight in both locations until the end of the agenda. When we get towards the end of the Q&A, we will stop the live feed on Facebook and we will stop recording, which we are recording now. So that way, if anybody wishes to ask a question and not have it in perpetuity journals on the internet, they will have an opportunity to ask a question. I do have to remind you that it is not a private question because there are other people in the webinar as well, but it will not be recorded or shared through social media or on a website. So that opportunity is at the end of the evening. I do want to let you know that we have some upcoming events at the HCMA and you can go to our events page and see where they all are. We have our online support groups, which I'll talk more about later. Tomorrow morning at 11 a.m. Eastern time, so bright and early out there in Oregon, we are going to be doing our Tales from the Heart podcast with Dr. Marty Marin and a very special patient story of a woman who ended 2020 the way many of us feel like we did. She had her heart ripped out. She transplanted on New Year's Eve. The first stitch went in before midnight and the last stitch was finished after midnight. So is she the last of 2020 or the first of 2021? Come hear more about that tomorrow. So I wanted to also remind you that there's going to be a poll for those of you who are in the room. I will make that live in just a few moments. And we ask that you take the poll so we know who's joining us tonight. And after I'm done speaking later on, we will review who's with us tonight so the staff will understand exactly who they're talking to. I want to thank our sponsors. There's a name here that you might not have thought, and it's changed recently. So Bristol Myers Squibb, which is the parent company now of Myocardia, Cytokinetics, Invitae, and Boston Scientific. We thank them for their support of this tour, and without their support, it would not be possible to bring you such good programming. I want to introduce two members of my team, and that is Julie Russo and Valerie Ventry. Julie is our volunteer coordinator and Valerie is our Center of Excellence coordinator. coordinator, and they have helped bring this meeting to fruition. And we want to send our warm wishes out to Amy Mann, our meeting coordinator, who is recovering today after her very successful right and left heart cath to check out her transplanted heart. So without further ado, I am going to introduce the audience to the director of the HCM program at Oregon Health Science, Mahad Mazare, and he is going to introduce you all to his staff. So I'm going to stop the sharing of my screen now, and we have the Brady Bunch view. Off to you, Ahmed.
Fantastic. Thank you, Lisa. Thanks, Valerie and Julie, and thanks for everyone who's joining us tonight. I'll share my screen here. I'll just take this opportunity to introduce you to our center here at OHSU, Oregon Health and Science University. As many of you know, while you interact mainly with probably 2 or 3 physicians and healthcare providers across within the center, but really we work closely together in order to bring you the best care we can provide, translating from the clinical care, surgical, procedural, all the way to the research aspects of it. As Lisa mentioned, I direct the center. We have with us today Dr. Howard Song, who is our cardiac surgeon who specializes in myectomy and mitral valve procedures. Dr. Balaji, who is our pediatric electrophysiologist and pediatric cardiologist, and he specializes in hypertrophic cardiomyopathy. Dr. Nazir, also with us tonight, and he is an electrophysiologist who specializes in arrhythmic issues in hypertrophic cardiomyopathy, but also runs a basic science lab focused on using ultrasound to ablate lesions related to hypertrophic cardiomyopathy, and he will probably be sharing some of the advancement there with you. We have Miss Megan Manillo with us also tonight. She's our dedicated cardiac genetic counselor, and many of you know her, as well as Katie Fisher, who is our nurse coordinator, and she is really the one responsible for making sure all of this ship continues to sail successfully. And then we have Dr. Akoven is not with us tonight, Dr. Sigarowa, Dr. Devanji, all of them work with us on the interventional as well as the clinical side. And we have Dr. Chen with us, who is our cardiac pharmacist. As many of you know, who follow up with us, Dr. Chen is an amazing team of our member of our team who helps us secure medications to patients, as well as help patients navigate this complex web of pharmacotherapy. And Dr. Steiner is not with us tonight, but he's our advanced heart failure and that transplant physician. And we have a very large team. Not all of them are here listed, of individuals who help us achieve our research mission also. I left these up here. You can note them down or come back for them for referrals. My personal email at the work here, my work emails, please, no medical questions, but if you have any general inquiries, you're more than free to email me, as well as we have an email for general research inquiries, and this is our website here. And I want to again thank Lisa and the HCMA for really bringing this tour, as well as all other tours across the United States, so that we can empower our patients to make better decisions and being able to navigate their complex care across many different centers in the nation. So I'll turn it over to Lisa. I'll stop sharing right now.
Fabulous. Thank you very much for that good introduction. Note to team, we should encourage everybody to do a slide like that, because that was really helpful. Okay, I'm going to go to a screen share here for a moment. Well, not for a moment, for a few minutes. And we're going to talk about some of the programs of the HCMA and a little bit about what you can expect tonight and in the future. I have launched the poll. Anybody who is in the Zoom webinar, and please take a few moments to answer the poll, and I will bring the answers to you at the end. You just click on the little survey thing. You know me and surveys. Okay, so tonight is Oregon. Next month is Atlanta. So come back and join us again for a future event, because each one of these programs is just a little bit different. And we're hoping that while we go through the next few years of these cycles and doing at least one of these meetings per month, that we are really showing the wide breadth of knowledge and experience of all of our different HCMA recognized Center of Excellence partners. And you're going to get slightly different agendas and different points of view from each of the programs. So tonight we're going to be doing a little bit of an update. Where are we in 2021? And we're going to hear about that. Then we're going to just break it down into some basics tonight. Rhythm issues in HCM. So we'll be talking about atrial arrhythmias and ventricular arrhythmias. And then we'll be talking about surgery. Y'all know we all like to talk about myectomy. So there's going to be quite a bit of that tonight. And unique to this meeting, we are going to have a real focus on pediatrics. And I'm happy to say that our presenter this evening and I have been in communication about working on a larger project specific to the HCM population and the pediatric groups so that we could better understand needs and identify where some gaps might be that we can help improve upon in the future. Then we'll be doing some Q&A, and your questions are always welcome, also by using the Q&A box at the bottom of your navigation bar in the Zoom room. Your question may not be answered till the end of the evening, but if you want to get it in there, you can do that at any time throughout the entire night. Again, thanks to our sponsors, without whom this wouldn't be made possible. So I want to start off with talking about the reality that is most HCM patients experience. It took us a while to get to diagnosis. Many of you were told you had asthma, specifically athletically induced asthma, panic or anxiety attacks, depression, mitral valve prolapse, or an innocent murmur. We know it took a lot of you a long time to get to proper diagnosis, and that is a frustrating battle. It is our goal at the HCMA to shorten that timeline from first symptom to recognition of HCM. And a lot of the programs you're going to hear about tonight are focused on that earlier time to diagnosis and treatment, as well as getting our community a little bit more conjoined so that we can all be working on unified missions and projects. We know that many people with HCM have different presentations, and that some of you are at high risk for cardiac arrest. Some of you have obstruction and heart failure symptoms. Some of you have non-obstructed HCM and advanced heart failure issues. Some of you are at risk for AFib or stroke. And some of you lucky ones are asymptomatic, low risk, and you're just being followed and you're not even on any medication. This is a complex pathway because it's not a disease. It is a disease process that can present itself in different ways to different groups. And that's why it's really important to get to care that understands that. Why is my mouse not going? There it goes. So if you were to look at all of the cardiologists in the United States and see how many patients they treat on a regular basis, you would see that the number is averaged at 2,000 per practice. If that is true, then about 10 patients are in each one of those practices. And when you have something as complex as HCM with all of these different variables, you don't know the experience level of a local cardiologist who I'm sure is well-meaning and a great person, but they don't have a lot of experience with our type of hearts. So it's important to us to ensure that you have that high quality care. And that is why we have been working for the past 20 years on the HCMA Recognized Center of Excellence programming. And we have different programs around the country, which we're going to talk about in a little bit, but they all share some basic principles. So as of me updating this slide today and a conversation with Valerie yesterday, as of February 2021, we have 41 centers. I forgot to change the color of the dot, but we haven't made the formal announcement yet, so I won't do that yet. But we have 12 inquiries in-house, which means as soon as COVID breaks and we're able to get out to some of these centers and the centers are able to spend more time on growing programs rather than trying to survive an international pandemic, we will have another 12 programs on the charts, hopefully. So we are adding some new elements for our newer programs because not every program is an academic center and not every program has access to high volume thought leaders in the field of HCM. So we are hopefully going to be getting funding for our mentorship program, which will allow seasoned mentors to help smaller programs in a structured fashion to ensure patient safety as these programs are developed. So stay tuned for more information on that. We're really excited about it. So your center, you have a director. And in all of our centers, we refer to our directors as hocomologists. You can thank Dr. Harry Lever at the Cleveland Clinic for that terminology. So your hocomologist, you have just met. Now we want somebody to coordinate all the care. And we want somebody to be the touch point. Now, sometimes it starts as a person and then it grows to a team of cardiologists. But what's important is that there's a connection point and that all these patients come back to this point throughout the journey. Because as they go through this process, you're going to see that for periods of time you end up in different buckets. But when you go to those buckets, it might be maternal fetal medicine, it might be genetics, mental health, interventional cardiology, surgery, EP. You should always go back to your HOCMologist and make sure that your care is consistent throughout the entire team. Teams are not one-person entities. They are a group of professionals working together to provide you the best care possible. They might disagree sometimes on strategy, so you might get a little confused as they're debating things to do too. But HCM is really an art form, and you really need people who know how to paint with that brush and understand these unique hearts. So this is a new slide for me. I just kind of created it today. You know that we've recently updated the guidelines in HCM. It was published in November. If you've been in another Bighearted Warrior tour, you've heard some talks on certain aspects of this new document. It's an update from the previous guidelines, which were 2011. But what is different here is that there's a very specific call out for the issue of multidisciplinary HCM teams. I kind of have to grin a little bit at this one because this is the patient organization helping guide where the future was going to go, because we call these HCMA recognized centers of excellence, and we kind of created the model, and it's been recognized now by the major players in the field, AHA and ACC, that this is the best model of care, and it has been proven in publications and in scientific literature. So we know that there's different types of programs. Some programs don't have surgery or don't have transplant. That's okay. They may have strong programs up to that point and referral arrangements for those who need to go down those paths. What I want to make very clear on this slide is, as important as high volume care is, your community cardiologist is critically important to the long-term success of a good management strategy. So we encourage all patients to have a hometown cardiologist that is working in concert with your center of excellence, and that the direction is coming from the center of excellence on your care, not the local cardiologist. So you have to find somebody who's willing to work with you on that. Most people nowadays are pretty open to doing that because they understand HCM is complex. And if they don't understand that HCM is complex and they think they want to manage you, that's a pretty good time to go find a center of excellence or another local cardiologist. So what do we know and why high volume centers? You can go to the document, read it all yourself, but it has been proven that the multidisciplinary approach is the most successful in treating people for the most optimal outcomes. And we know, as patients and families, we want the best outcomes possible for ourselves and our loved ones. So this model does work best. What do we know about the patient's perspectives? We've interviewed many people, we've done surveys. We know that patients who have been seen at a center of excellence have identified that their physical and emotional quality of life is improved. They have lower complication rates when having invasive procedures like alcohol ablation specifically, or myectomy in low volume centers can be, we know, very dangerous, or their devices are placed and they're happy about that. They also have the ability to participate in clinical trials, and there's going to be some new ones coming up, and I can't even tell you everything I know yet, so stay tuned for more on that one. So I want to talk about our support systems. You're going to see, hopefully next week, a new page launch, probably not going to be used by anybody here, but you never know. The HCMA official Facebook page is going to become an anchoring point for some international programs. So we will be launching HCMAI International Sweden in the next couple of weeks, followed by Italy after that, and there's a few other countries in line behind that. We are trying to find our patient advocate partners in these countries to help them develop stronger networks so that people can get information and support in their native language. We have our support group system now, our online support group system. We just finished up a little while ago here on Facebook, interviewing all of our support group volunteers. And I encourage you to go back to the Facebook page, and you can see all of these people tell you a little bit about what they're hoping to do in their individual support groups, what their experience is. You might find somebody you mesh with. I got an email from somebody excited because one of the guys is an amateur astrologer or astronomy buff. And he's like, oh, I love astronomy. So now they found a bond, and now they'll go talk about HCM and astronomy together. We have former writers from the New York Times, lawyers, a couple lawyers actually, PAs, patients who have experience in patient education and are also HCM patients. And we even have a teen and young adult room that is going to be co-moderated by myself even though I'm not a young one anymore, and Amanda, a sudden cardiac arrest survivor who is in high school. So we have a really robust, different team here. We have men, women, older, younger, so you'll find something that fits you. Okay, this is gonna be a program we're gonna roll out next year or late this year. This is our peer-to-peer Bighearted network. If you're not a support group person, but you wanna talk to somebody else with HCM, we're gonna be creating the eHarmony of HCM. Stay tuned for that one. Tales from the Heart, I talked about this earlier. We do a live broadcast every other Friday from the Facebook page. It is then recorded and uploaded to wherever you get your podcast from. We're on iTunes and Spotify. It's called Tales from the Heart. Sometimes it's conversations with cardiologists. Sometimes it's industry representatives. Tomorrow it will be a heart transplant recipient with an amazing story. And she's a patient of Dr. Martin Marin. So we're going to be kind of having a three-way conversation about what the process looked like and where there were some unique moments. It's a bit of an inspirational story, a little scary at times, but at the end, it all works out pretty well. Did I just give away the ending? But it's worth hearing. Okay, so we have some new committees that are forming. And by the next time I give this talk, there's going to be a very different graph here. We're about to launch, honestly, a new way of doing our work. And we are going to go to a very committee-focused model. There will be a medical affairs committee, a patient education committee, a diversity committee, a legislative subcommittee I'll talk about in a moment, a finance committee, and then a couple of other subcommittees that are already percolating. We are going to be looking for volunteers to help on these committees to help guide the future of the HCMA. Yes, I'm the founder and I'm the CEO, but this is a much larger organization than one person or a couple of staffers. This is an international movement, and we're going to need everybody on board to make sure we stay on focus and that we're getting the important work done that we need to get done. So I would encourage you to stay tuned for more information on how you all, medical professionals, families, patients, that you're all going to be able to get involved and have a seat at the table to help guide the future. So the biggest advance that we've had in a committee yet is our legislative subcommittee. And we hope to launch in the next couple of weeks some state-based initiatives where we are looking to include cardiac components to a well child examination like we do here in the state of New Jersey. New Jersey is the only state in the country that actually asks any questions of a young person's heart at all. So that's a little silly, and it's very cost effective to just look for family health history and look for some signs and symptoms of not just HCM, but any form of heart disease in the young. So that's coming up. Stay tuned for that one. If you have not watched our PFDD, our Patient Focused Drug Development meeting, I encourage you to do so. It's 4.5 hours. It's really long. It's very comprehensive. There's a report online right now. I'm sorry I forgot to link it here. But if you go to our website and type in Patient Focused Drug Development, you will get the Voice of the Patient report, and you can see what actually happened there. This was our opportunity to talk to the FDA and get on the federal record what patients with HCM want and need and what our burden of disease is. So it very clearly lays out what our problems are and what we're hoping that we will, what just happened there? Don't even know. I don't even know what happened there, people. That's not good. I'm going to do a stop share for a second. And then I'm going to try to get my other slide back up. I have no idea what happened. My apologies. Okay. 1 second, please. I don't even know where you people all just went. There you are. Sorry about that. Just one more slide for me, and then we'll get back to the agenda. I don't know what happened there. There we go. So I wanted to say thank you to everybody, all of our partners at the Center of Excellence programs around the country, our staff, our board members, our volunteers, and Brandy, for those of you who do not know, was my heart donor's name. And without Brandy and her family, I would not be with you here today. If you are thinking about joining up membership to the HCMA and helping support our mission, right now we still have free 23andMe kits available for request if you are a paid member. It's the contract. It was a gift in kind from our friends at Myocardia. So no strings attached. It doesn't do HCM genetics, but if you would like a history and ancestry kit, all you need to do is become a member and put in an order. And on that note, I'm going to hand it back to Dr. Masri, who is going to talk to you about HCM in 2021.
Fantastic. Thank you, Lisa. That was great. You know, when we talk about HCM, we can spend really probably all day or all week talking about different aspects of it. But I thought I'll pick up some points there to highlight how the care of HCM is really changing in 2021. And so those are my disclosures, but I'll only, the pertinent ones that I'll be discussing, mavacamten and CK-274, which are not FDA approved. And so when you look at the timeline of how HCM progressed over time, HCM care, the first description of pathological series in patients was back in the 1800s, but really the first clinical description was in the 50s. And from there, we progressed, surgery, early days of the surgery. Then we had echocardiography, beta blockers in the 70s. ICDs were introduced in the 1980s. And so the field really started growing more rapidly. Alcohol septal ablation was introduced also in the 90s. And so we're very proud here in the Pacific Northwest through the work of different people at Oregon Health and Science University. My partner, Steve Heitner, who many of you know, drove a lot of the research and work that's been done using new novel agents such as mavacamten, which I'll briefly touch base upon. And also part of our team here in the basic science world also worked on correcting a genetic mutation of an HCM embryo. And so, it's really an exciting time to be taking care of patients with HCM and to be in this field, because this is just, the revolution here is starting. And so when we'll focus a little bit about the management and how this could change with time. If you notice, the title is "The Future is Now," because this is really rapidly changing. So this is the classical type for obstructive disease, and also for non-obstructive disease, just for the beta blocker and calcium channel blocker. But if you focus on the obstructive disease for a second there, this is the traditional treatment. You start with some medical therapy if you're symptomatic. If you're asymptomatic, sometimes we don't treat. And then if medical therapy does not work there, then we progress to an intervention with either surgery or alcohol septal ablation. And so through the work of many, many people throughout the years, as well as thanks to the centers of excellence, as well as the centers who focus on HCM worldwide, this mortality of HCM have changed. This is from Dr. Marin's paper that showed that the mortality is decreasing from the early HCM cohorts, which was about 3 to 6% per year, coming all the way down to 0.5% per year. But one thing to remember, this is really in referral centers with highly specialized care and delivered by centers of excellence who have access to a lot of things that in the community not everyone has access to. And so this is the reality of everyday practice. And this is not to scare anybody, but this is partly why the work that the HCMA and Lisa are doing is so important. If you look at myectomies, this is data from 2016 over 1 year period. 60% of hospitals in the United States performed less than 10 septal myectomies. And as you can see here, this is the majority performing less than 10, some of them even less than 5. And so this is a scary number. We're talking about taking somebody who's doing reasonably well, but they're having a lot of symptoms, living with HCM. And we're saying that the mortality should be less than 1% or so if they're not high surgical risk. But we're seeing that in the lowest volume hospitals, the mortality is about 15.6% or so. And the rates are also higher for pacemaker need, for stroke, for all that. And so we really need to focus more our effort. It's not that we need to create only a single place in a huge geographical area that takes care of patients, but when it comes to highly specialized care, that's probably beneficial to patients for patients to happen. And so this paradigm is rapidly changing. I'm gonna only focus on the newer medications that are coming down the pipe, but most of the other speakers, Dr. Nazi, Dr. Song, Dr. Balaji, and Megan Manello, will be discussing some of the advances in different aspects of HCM. I'm not going to go over this mechanism, but there are really newer targets and recent advances in HCM that are very exciting. The whole point, if you want to just remember one thing, there is hypercontractility in the heart in patients with HCM. So there is a lot of sliding, cross-bridging. So think about the heart as having fibers, and those fibers interact with each other more than they should in patients with hypertrophic cardiomyopathy. So what we want to ask the heart and those fibers is to relax. And this can be achieved through a medication or a group of medications now. But the first one that was introduced is mavacamten. And so this is from the Explorer study that was published a couple of months ago, showing that for patients who were randomized to the medication compared to placebo, there was 20% absolute difference. What does that mean? That means that in a good proportion of patients, they felt better, as well as there was an objective evidence on testing that their heart efficiency improved. And so that's very important because these are hard endpoints sometimes to achieve. And so, but what do you, for patients who think about this more, they always look at their gradients, at their ejection fraction, and those numbers on the echocardiograms. And this is a snapshot of the trial. Patients who exercised were obstructive. They had gradients in the 80s. And then when they were treated over 30 weeks, their gradients dropped down to 30s. That's below the trigger to say, well, you're not doing too well, maybe with symptoms, let's send you for an intervention or surgery. And this while maintaining their ejection fraction and not dropping it. Because again, remember, we're asking the heart to relax. When the heart relaxes, that obstruction goes away in the majority of patients. This was an important trial because it was the first one. So they wanted to really keep an eye on safety. So we were not way too aggressive in titrating these medications. And I'm sure many of you in the audience have participated in this trial. And thanks to you, without you, really, this would not progress anywhere. And so what are the advances and what's happening now in 2021? This is the second step of taking mavacamten and testing it in the Valor HCM trial. And so if somebody is eligible for myectomy or alcohol septal ablation because they have way too many symptoms still, despite that being on maximal medical therapy, then they would be randomized to mavacamten, or essentially being asked every time point in the assessment if you want to proceed with surgery or not, or with alcohol septal ablation. So that's a good way of testing if mavacamten can be effective enough that patients don't want to proceed with surgery or with procedures like ablation. Another one is a cousin of mavacamten, but with a shorter half-life. It's called CK-274, and right now is being tested in this phase 2 trial. And again, thanks to our patients here in the Pacific Northwest, we are probably the top enroller or one of the top enroller centers, and a lot of our patients have been participating, and we'll find out the results in the next couple of months. So not to forget non-obstructive hypertrophic cardiomyopathy. I know that this group has been less focused on in terms of therapies and in terms of advances, but we also are looking at newer medications in this sphere. Many of you know this medication. It's called Entresto or sacubitril valsartan. It's used in heart failure. Now it's being trialed in non-obstructive HCM. We're participating. There is newer trials of energy modulators. I'm not going to go into the details, but the idea is to help the heart again work more effectively and more efficiently. And then the same cardiac myosin inhibitors you just heard about, mavacamten and CK-274, will be trialed more broadly in this disease. Again, many of you participated in the Maverick study, which looked at this in non-obstructive disease, but now we have to take this to the next step for larger trials and see how it actually helps patients. So just a couple of slides on diagnostic testing, because I think this is very important. Really, all of you undergo echocardiograms, and all of you are familiar with them. Most of you underwent cardiac MRIs, but not all of you. And we see this all the time. Really, unless contraindicated, absolutely should not be done. Every single patient who receives a diagnosis with HCM should get a cardiac MRI with something called T1 mapping. The reason behind that is we want to look at scars. So here, the normal heart is black. The normal myocardium or the normal tissue of the heart should be black. And then anything that is white within the heart is fibrosis or scarring. And then as you can see here. And so this is one of the reasons we do this. But the second reason is there are a lot of rare diseases that resemble HCM. And we want to make sure that we are actually giving patients the right diagnosis. That's why MRI is very helpful. Another point is genetic testing. Here at OHSU, as many of you know who follow up with us, we recommend genetic testing for most of our patients. This is MRI, this is echo, showing you different types of hypertrophic cardiomyopathy, different phenotypes. And then the yield of genetic testing depends on the phenotype, but still we do recommend genetic testing for the majority of patients with exceptions. You will hear more about this from my colleague, Ms. Megan Manillo, after Dr. Balaji touches on some of the pediatric issues within HCM. And so this is our cardiogenetics program at OHSU. Megan probably is the only dedicated cardiac genetic counselor, I think, in our state, and she really delivers excellent care. We review together each referral's history and imaging, because we really don't want healthcare providers to just be looking at the genetic testing report and say, well, you're positive or you're negative. It's more or less, you have to think about what does the patient have to begin with from a disease standpoint, and how can we tie that to the genetics that we run for them. And also we work with companies and we work with families to try and reclassify these uncertain results, because if a family has a lot of these uncertain results, then we can work together in order to try and further our knowledge about HCM. And so in conclusion, this is really an exciting time for the HCM community and for us physicians taking care of HCM patients. The multidisciplinary approach for HCM is a must. And then personalized medicine approach, which you hear about all the time, but it's actually been here for HCM all along. You just need to be at a place where you are being offered all of these potential opportunities as well as advances for treatment. And then effective new therapies are being trialed. Inquire either locally or with us if you would like to participate. And then finally, really, I want to thank all of you, patients living with HCM. I want to thank the HCMA as well as our clinical and research teams for all the hard work that they do. I'll turn it over to
I'll take it for a minute, and I'm going to pass it back. I just wanted to go over the poll real quick.
Okay.
And share the results of the poll, and Dr. Nazar can get his screen share ready. We are predominantly in the Western United States. Surprise, surprise, if we're talking to our West Coast buddies. We have some people from the Northeast, Southeast, Midwest, Canada. No foreign nations tonight. 65% of those watching are patients, and 16% additional are patients who also have a family member. Some of them are family members, and somebody's just curious. I find that interesting. Here's the curiosity. So what have you done? So 23% have been diagnosed within the last 2 years, which we know is the steepest learning curve for those with HCM. So hang in there. We'll get you through the hard stuff. 75% or thereabouts are on medication. 48%, we got a large ICD population. 19% have had septal reduction therapy, either myectomy or ablation, alcohol septal ablation. 29% have atrial fibrillation. 26% of us have lost a family member to HCM. I'm the only heart transplant patient here tonight. 65% have had genetic testing, and excuse me, 6% have been advised to get an ICD, but have not done it yet. And another 6% have been told to get a septal reduction therapy, but have not done it yet. So we have some people making decisions tonight, some people learning, and somebody who's just curious. Okay, I'm going, whoops, what did I just do to my screen? I'm going to hand it off to Dr. Nazar, who's going to talk about rhythms in HCM.
Well, good evening. Thank you, Lisa. Thanks to the HCMA team, first of all, for staying up so late into the night East Coast time to put on this event, but also for providing access to our patients to get to know and meet each other, and then also for us healthcare providers to interact with them in a great venue like this. So those of you who don't know me, I'm Bob Eknazer. I spent half of my time as a physician scientist researcher here at OHSU, and the other half as an electrophysiologist. And as a result of that, have a few very narrow clinical niches so that I can be pretty good at a few narrow clinical things while I devote time to research. And one of those clinical niches is HCM. So it's been a real honor to be part of this group that Ahmed introduced. So I subtitled my talk, Options, 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 and you'll see why. And in the past few years, on the heart rhythm side of HCM, we've had the proliferation for better or for worse, of more and more options to our patients for all the rhythm issues that come up. So let's proceed. So we'll discuss options and the risk stratification of the life-threatening arrhythmias. There are new options for those. We'll discuss the newer options in implantable cardioverter defibrillators, ICDs. We'll discuss some new options in atrial fibrillation therapy that weren't available to us. And Ahmad described some of my research aspirations. We'll discuss some potential new options for septal reduction therapy that my research lab is working on. And I'll leave some time for questions. So let's start off with risk stratification for ventricular arrhythmias, or the dreaded sudden cardiac death. Well, a lot of this has been shifting recently, and frankly, in the direction of more options. So our very first iteration of the HCM guidelines in 2011 put out a fairly straightforward algorithm for determining who should be recommended or offered in a reasonable fashion, or really not recommended an ICD. But since then, as the data has grown, so have the options. So the European Society of Cardiology, put together a more quantitative approach to risk stratification, where we put in several characteristics about our patients, and an equation basically spits out a 5-year risk of a dangerous life-threatening arrhythmia occurring. And then we use that number combined with the level of recommendation associated with it to guide patients as they decide whether they want one of these devices. More recently, we've had an enhanced version of our original 2011 criteria investigated by some HCM groups. And that has culminated in the 2020 guidelines that Lisa introduced at the beginning of this section, having somewhat of a new and improved algorithm for risk stratifying patients. So I don't think that more options is always necessarily good. I should say that all my patients don't. Some patients just want it to be binary. They want to say, do I need one or do I not need one? And I wish it were so black and white. It's not always. But what I prefer to do is look on the bright side of having more options and incorporate these into shared decision making. Those of you in the audience who know me know that I like to make decisions as a team. The patient, the patient's family, me, and the HCMologist, as we call it. We all weigh in and we all make a decision, with the patient being the final arbiter. And more risk stratification models means more ways to just have that shared decision-making conversation with the patient. A few of the more recent risk factors that have emerged that have been pushing us toward ICDs: patients with aneurysms in their left ventricle and patients with reduced ejection fractions. So let's move on from options and deciding who needs an ICD or should strongly consider one, to new options and types of ICDs. There's the more tried and true, been around for 30 years, transvenous ICD, where the battery or generators, it goes under the left collarbone usually, and the leads go into the right ventricle and sometimes also the right atrium. And then there's the relatively new kid on the block, which is entirely subcutaneous. The generator is under the left armpit, but outside of the rib cage, underneath the skin. And the lead gets tunneled under the skin again and takes a 90-degree turn north and goes up to the top of the breastbone here. Both have their relative benefits and drawbacks. I don't want to go into these in depth. I've put them up here. Many of you know a lot about this, and the HCMA has provided a lot of access to learning more about this complex decision. But one of the new option issues is that when the subcutaneous ICD first came out, it was thought that it was going to be associated with a lot of inappropriate shocks. And initially, early on, it was. Like in the 2000s, it certainly was. And partially due to the company getting better at the device's function in sensing arrhythmias, but also due to us choosing the right patients, we've really reduced the number of inappropriate shocks. We recently teamed up with 3 other HCM centers, one in Italy and 2 others in the United States, to combine our data on all of our HCM patients with subcutaneous ICDs. And we found that with modern programming, we've really gotten the rates down to around 5% of patients getting shocked when they really didn't need to. And this is a fairly complex and busy slide, but here at OHSU, we have a few enhanced ways to screen patients, both before we put the ICD in, the subcutaneous, and right after we put it in. to really decrease the risk of inappropriate shocks, and also have ways of responding to an appropriate shock to make sure another one doesn't happen again. We've also published this work recently. So moving on from the more dangerous, life-threatening ventricular arrhythmias in the lower chamber to the frankly more common, but luckily not directly life-threatening upper chamber, let's discuss new options in atrial fibrillation therapy. Atrial fibrillation is the most common arrhythmia there is in all comers, even outside of HCM. It's usually an age-related condition, but in HCM tends to affect patients at a younger age than in patients who don't have HCM. And one of the issues with atrial fibrillation is that antiarrhythmic medications, the medicines that nip it in the bud from happening, all have their own complications, many of which are pro-arrhythmic. And until very recently, the antiarrhythmic medications that were available to HCM patients were very narrow and limited. It was really just amiodarone. And this derives from some earlier recommendations. This is a 2014 AFib guidelines that told us that pretty much every other medication other than amiodarone was not recommended in anyone with an LV wall thickness of more than 1.5 centimeters. This wasn't an HCM specific statement, but as most of you know, this captures most HCM patients. And so all we had medication-wise was amiodarone, which, while very effective and safe if monitored closely, is not ideal at high doses or for many years. So luckily, due to efforts of our colleagues at other centers in 2018 investigating dofetilide, and in 2019 investigating sotalol, our most recent iteration of the HCM guidelines in 2020, frankly, liberated us as patients and providers to start to use sotalol and dofetilide with the appropriate amount of monitoring, and really use this recent data on the safety of these medications to broaden and create new options of the medications available for patients. Now, there is a whole other group of therapies for atrial fibrillation HCM patients, and that's ablation. And this is an area where, our early data shows that it's not as durable of a therapy as we'd like. So typically, catheter ablation for AFib, long-term, it's really about 50-50, whether a patient's AFib stays away or recurs. Many patients go on to need multiple procedures, and many patients will need the ablation plus one of those three medications, sotalol, dofetilide, or amiodarone. We're getting better at this. We have a lot more work to do. Patient selection is key. We certainly have many patients who've been free of AFib with HCM for many years after an ablation, but we have more work to do in patient selection and the procedure. And lastly, I want to finish with something near and dear to my heart, and that's new options for septal reduction therapy. Everyone's familiar with HCM on this call, and Dr. Song is going to tell you much more about septal myectomy surgery. And alcohol septal ablation is a fairly well-described alternative that's a little bit less invasive, arterial access, usually via the groin. But as both Lisa and Ahmad described, these two septal reduction therapy procedures, while they are fairly effective and quite safe at high volume centers that are HCM centers of excellence under experienced hands like those of Dr. Song, when you look at all comers, when you look nationwide, worldwide, the majority of these are being done at low volume centers. And that's when the rates of perioperative and periprocedural mortality, arrhythmias, heart block requiring pacemaker, that's when the rates of those really go up. So we're lucky to have Dr. Song. We're likely to be an HCMA center of excellence, but there certainly is a need for another method. They may not have such a long learning curve. So my research background is in medical device development, particularly therapeutic ultrasound. Most of you know of ultrasound as a diagnostic imaging tool through echocardiograms. Turns out if you turn up the power, you can actually use the ultrasound catheter to heat tissue and ablate it. So in my laboratory, my engineers and I build these catheters from scratch. Here's a zoomed in version of a catheter tip. It's about the size of a straw, a standard drinking straw. We simulate and model these through software, and then we test them once we've built them. And we've investigated these in large animal models. Our catheter goes into the femoral vein. This is under X-ray guidance. We point the ultrasound transducer from the right ventricle to the interventricular septum, and we can create lesions, deep lesions right in the middle of the septum. We survive these animals for a month, and there at 1 month, you see the interventricular septum is remarkably thinned. We've done MRI on these swine and a whole host of other studies that I won't bore you with, just to let you know that here at OHSU, not only are we involved in all the clinical trials of the medications, but we also have some therapies in the pipeline as far as procedures and devices. So with that, I'll thank the patients and the HCMA and leave time for questions.
I do have some, I'm here somewhere. I do have a couple of questions that I just want to clarify for Diamond Dave. Love the name. ICD does stand for implantable cardioverter defibrillator. LVOT is left ventricular outflow tract obstruction. And the other question is LVOT is specific to obstruction in HCM, and you see an increase with exertion. Okay, so we got all that done. We answered those. Okay, so they're all answered. If there's any other questions, please use the Q&A panel. Thank you for that great talk. I didn't want to miss this opportunity to clarify anything that might have been unclear to somebody. So the ongoing battle of trying to do anything but myectomy to get rid of outflow tract obstruction leads us right into a conversation with a cardiac surgeon who does exactly that all day, right? So I think we're going to hand it over to Howard Song, who's going to talk to us about myectomy, but I'm going to come back to you guys at the end with some questions about strategies and this new procedure you just discussed and how it might impact decision-making around the country on how to manage outflow tract obstruction. My cat's yelling in the background, sorry.
Hi, everyone. This is Howard. I hope you all can hear me. Please send me a chat message if my voice is too soft or you have trouble understanding or seeing the slides. I want to start out by, again, thanking Lisa for organizing this and giving us the opportunity to interact with our patients. This is just a wonderful opportunity. Lisa, you are an amazing advocate, and we are all lucky to have you. So again, thank you. I am a surgeon here at OHSU, and one of my special interests is in surgery for obstructive hypertrophic cardiomyopathy. And I'm really happy to be able to kind of give an update on what we consider to be the modern approach for treating obstructive hypertrophic cardiomyopathy with surgery. So I'll just give a couple of slides about hypertrophic cardiomyopathy, some of the associated mitral valve abnormalities that almost all patients with obstructive hypertrophic cardiomyopathy have, because I think they're very pertinent to the discussion about surgery. And then, as I said, we'll go over the modern operative management of obstructive HCM, which starts with an intraoperative evaluation, what we consider to be a standard, and then extended myectomy, and then other associated procedures that we feel are important to address all the anatomic abnormalities that are contributing to obstruction. And these are mitral leaflet shortening procedures. The approach we use is called papillary muscle realignment and resection of various chordae, bands, and accessory papillary muscles. And then I'll give a slide or two about our outcomes here at OHSU. So for anyone interested in relieving obstruction with surgery, the most important thing to understand is patients with HCM have different septal morphologies or different shapes to their hypertrophied septum. And so it's just important to keep in mind, anyone who's planning on operating on someone with HCM, about half of our patients have this sigmoidal morphology or shape to the interventricular septum. That's this area here. This tends to be the shape that we see, especially in some of our older patients. Younger patients can have this reverse curve morphology. Both can be relieved well with surgery, but it's just important to know what you're getting into beforehand. And then there's two less common versions, apical and neutral morphologies. Again, I want to emphasize that there are associated abnormalities that almost every HCM patient has who has obstruction. And it's important to know about these because they contribute substantially to systolic anterior motion of the mitral valve and left ventricular outflow tract obstruction. This schematic just shows all the different variations that occur in the mitral valve in patients with obstructive HCM. With HCM, of course, we always think about the hypertrophied septum or muscular element of the heart, but patients with obstruction also very commonly have abnormalities of the mitral valve. Virtually all obstructive patients have elongation of the mitral valve, anterior leaflet especially. Virtually all have displaced papillary muscles, and then many have aberrant abnormal papillary muscles. And then there are many other little bands and chordae that are associated with the mitral valve that can also contribute to obstruction. So obstruction in a patient with HCM is really an interaction between not just the hypertrophic septum, but also the mitral valve. And so I kind of think of it as two hands clapping. You can't clap with just one hand. You can't have obstruction with just a hypertrophic septum. There has to be some interaction with the mitral valve also. And because there's this interaction with the mitral valve, it can be influenced by parts of the mitral valve like the chordae, bands, and papillary muscles. This is a cartoon that depicts what happens during obstruction in HCM. It's a cartoon of the left ventricle. The left ventricular outflow tract is here. This is the area that gets obstructed before blood is ejected out the aortic valve to the body. This is the septum, which is typically hypertrophied or thickened in patients with HCM. And this is the mitral valve. This is the piece that interacts with the septum of the left ventricle to cause obstruction in the LVOT. You see, if the mitral valve is pulled over toward the septum, you get acceleration of flow and obstruction. And also something that many people don't think about is the mitral valve gets very distorted and causes what is usually severe leakiness of the mitral valve with exercise or stress. So here's a nice example of a patient with obstruction of the LVOT. This area here is the LVOT. You can see the interventricular septum is hypertrophied, but in addition, the mitral valve is very elongated. It's getting pulled into the LVOT and interacting with the septum to cause near total obstruction of the LVOT in this patient. So as you all know, patients can develop very high left ventricular outflow tract gradients or degrees of obstruction. The higher the gradient, the greater the obstruction. They also get severe mitral regurgitation, as I said, and then progressive heart failure, and then sometimes sudden death. This graph shows survival of patients with obstructive HCM in the brown line here. You can see It's in decline over a 10-year period. This is a study by Barry Marin. And it really gave us an impetus to offer surgery to patients who have obstructive HCM, because as you can see, if patients with obstructive HCM have surgery, then their survival is returned to a level that is more typical of a patient who has no obstruction at all. So this is really the justification for offering myectomy to patients. Myectomy has been around a long time, as Ahmed said. It was first described in the 50s. This manuscript is from the 1970s. Was the first series of patients that was described. I included it here because it shows a nice historical drawing of what myectomy used to look like. As you can see, it was just kind of a thin band of muscle that was resected from the ventricle, you know, really only about 1 centimeter wide. And, you know, these days we wouldn't really even call that a myectomy. We'd call that more of a myotomy, just making a slit down there, dividing the muscles so they couldn't thicken and contract. We've come a long way since then. We have what we think of as a modern operative management of obstructive HCM now. One of the tenets is that basically patients are evaluated for surgery based on the suitability of their anatomy and an assessment of their operative risk. We don't strictly use age as a selection criteria. In fact, we just presented a study which showed that across a very broad range of patients, including older patients, we can achieve really good outcomes for patients with obstructive HCM. In our center, surgery is frontline treatment for obstructive HCM. Only a very small percentage of patients actually wind up getting alcohol septal ablation or treatment with a mitral clip because we've been really satisfied with our results here. The management of obstructive HCM starts in the operating room with a TEE, or transesophageal echocardiogram, under anesthesia. We do the echo under anesthesia both before and after the surgery, and I'll explain why. First of all, when you take a patient who even has a high gradient with HCM and you put them to sleep under general anesthesia, because of the effects of the anesthesia, usually the obstruction goes away. It becomes occult. And so obviously, if we're trying to relieve an obstruction and there is no obstruction under anesthesia, it becomes hard to make a plan to do the surgery. So what we do in our center is after the patient is put to sleep, we do kind of a pharmacologic stress test by giving them dobutamine at a pretty high dose. And this is the equivalent of exercising someone very vigorously. And then we assess the gradient. The dobutamine allows us to assess the gradient, the abnormality of the mitral valve, and the degree of leakiness of the mitral valve, both before and after the surgery. And so that really allows us to plan a really effective procedure. This graph just makes the point of when you put a patient with HCM to sleep, their resting gradient goes from a very high abnormal level to a much more closer to normal level. But then if you give them dobutamine, and as you can see in this bar, their stress gradient goes, even though they're under anesthesia, goes all the way back up to the stress gradients that are measured in an awake patient as an outpatient. And then after surgery, we check to make sure that the result that we achieved is what we wanted. And so we repeat the stress test after the procedure while the patient is still asleep and confirm that the gradient is sufficiently relieved. And this is something that we do. It's part of our work, every procedure. This is a whiteboard that we keep in the operating room, and these are just notes to ourselves to see what the gradients were prior to the procedure and then after the procedure. And you can see in this instance, the patient's gradient was relieved all the way down to 21, even with stress dose dobutamine. Another aspect of our surgical management is to address all the associated features that contribute to the obstruction, not just do the myectomy, but address the mitral valve abnormalities as well. So we do the myectomy, we do a very broad septal myectomy that's much more extensive than what Dr. Morrow originally described in the 1970s. We resect muscular bands that are contributing to the obstruction. And then we resect chordae and anomalous papillary muscles as well. We deal with elongation of the mitral valve, primarily with a technique called papillary muscle realignment, and I'll show that as well. Surgery for HCM, I kind of think of it as trying to make a ship in a bottle because the left ventricle is very small. And so you kind of need instruments and tools that will help you reach down into it through a small opening and do all the things that you want to do. This is what a patient's hypertrophied interventricular septum looks like. It's just in the left ventricle, just deep to the aortic valve. This is a little bit of the aortic valve that you can see, and this is the left ventricular outflow tract. Opposite the septum is the mitral valve, and this is also how we do the work on the mitral valve that we need to do. We do a very broad myectomy. This is what it looks like after we're done. We go basically from one side of the mitral valve all the way to the other. You remember in Dr. Morrow's picture, he was just taking out about 1 centimeter. This is closer to 4 or 5 centimeters wide. And the reason we can do this, as Dr. Masri said, is we have very good imaging. Something like an MRI shows us the whole area that's thickened and gives us confidence that yes, this area is thickened, so we can resect it safely, and as well as this area. And that's how we get the very broad resection. This picture shows an apicoseptal band. There's a piece of muscle that is attaching the septum to the apex of the heart, and it's tending to pull the septum in closer to the mitral valve, and it's directly contributing to the obstruction as well. In this case, this was a band that we could resect as a continuous piece with the septum that was taken out. This is the myectomy specimen. You can see there's a white scar here that Dr. Masri also showed with the MRI. And attached is that apicoseptal band that is shown in the MRI. Patients also have accessory papillary muscles. It's hard to see in this echo, but the thing that's interacting with the septum is actually a papillary muscle and not the mitral valve. This is what it looks at the time of surgery. There's this accessory papillary muscle that's inserting high on the mitral valve. And so this is the stump of the papillary muscle that we took out. This is where it was inserted onto the mitral valve. As you can see, if there was a structure here, it would be interacting with the hypertrophied septum that was also resected. So we took it out so it could not contribute to obstruction. Here's a picture of the same patient that we just saw who has now had a myectomy and also has had this whole area cleared out which is where the accessory papillary muscle was. And then lastly, the last thing I wanted to show was how we deal with mitral leaflet elongation. This is a little bit hard to interpret. I'll show some moving images later, but here is prior to surgery. You see the mitral valve is very elongated and it's pulled into the left ventricular outflow tract and interacting with the hypertrophied septum. And it's also causing a lot of mitral regurgitation on this side. Here after surgery, we put a stitch in the mitral valve to keep it tucked over away from the left ventricular outflow tract. And you can see this area is wide open. There's no obstruction. And also the mitral valve is working properly. It's not leaking at all. This is what that stitch looks like at the time of surgery. It's called papillary muscle realignment. It tucks the mitral valve back away from the left ventricular outflow tract. This is what a patient looks like prior to the procedure. Again, here's the left ventricular outflow tract. You can see it's obstructed by this elongated mitral valve leaflet with a very leaky mitral valve. Afterwards, there's no leakiness of the mitral valve. There has been a myectomy performed, and the stitch is also keeping the elongated mitral valve out of the LVOT also to prevent recurrent obstruction. You can see this is even done with a patient on the dobutamine. So this is the post-operative stress test that we're checking to make sure we got the result we wanted. Here, the yellow arrow is showing the stitch that we put in to keep the mitral valve tucked out of the way. So we feel like the outcomes that we get from this approach really justifies how we do things. You can see following surgery, patients have very reduced left ventricular outflow tract gradients, both at rest and with stress. And then just as importantly, you can see prior to surgery in the big black bar here, with stress, virtually everyone has a very leaky mitral valve. But after surgery with stress, none of the patients have a severely leaky mitral valve. And in fact, almost all of them have either no leakiness of their mitral valve or just mild leakiness of their mitral valve. Just a couple other details from this series that we published. We had a relatively low rate of needing to prolong the procedure by doing additional resection. There were no mortalities, and also there were no mitral valve replacements. This is a very important point. I think at less experienced centers, you might see mitral valve replacement in as high as 25% of patients. So we're showing that that is actually very avoidable. So to conclude, HCM is a heterogeneous disorder that is associated with mitral valve abnormalities that contribute to obstruction. We found that the intraoperative stress echocardiogram is very useful for planning of our surgery and to assess how good our surgery was. And we feel like our comprehensive approach addresses all aspects of the patient's anatomy, leads to reliable relief of obstruction, resolution of leakiness of the mitral valve, a return to excellent functional status, which I did not show with data, but we could, avoidance of dedicated mitral procedures, and the ability to treat a broad spectrum of patients and patient anatomy. Again, I want to thank everyone for your attention, and again, thank the HCMA and Lisa for the opportunity to present to you all. Like Ahmed, I did leave my email here. We can't really exchange detailed medical information by email, but would be happy to answer general questions.
So we do have a couple of questions coming in, and we do actually have one more speaker tonight. Megan is going to be speaking to us, but I wanted to, I'm going to steal the slide back for a moment.
Yes, I will stop sharing.
And I'm going to bring up a photo real quick as we go through some of these questions. Let me move this over, because you brought up one of my favorite people. I just have to, I'm sorry, I've been in Zoom world too much. You brought up one of my favorite people. You talked a lot about Dr. Morrow. And I think it's really important that this patient community gets to see this very important man in our history. This is Dr. Andrew Glenn Morrow, who practiced at the National Institute of Health and was one of the first cardiac surgeons really in our country. There were a few others at the time, but he was a pioneer. Please notice what is in his hand. He has a cup of coffee and a cigarette in his scrubs. What is more interesting about Dr. Morrow is he was a member of the tribe, folks. He had hypertrophic cardiomyopathy. He was diagnosed by Dr. Eugene Brunwald, the pioneer of cardiology, wrote Brunwald Cardiology. They were best friends. If you want to hear an amazing story that is just too strange to be true, you have to read his story. He was an amazing guy. He was big and boisterous. He was quite unorthodox from all rumors and stories. I was lucky enough to know his daughter for a good period of time, and I've spoken to his son recently. Unfortunately, his daughter went for a transplant and she didn't survive past 5 years, but it's an amazing family. It's an amazing history, the amazing contributions, and to prove that yours truly is a complete HCM geek, the original tools that Dr. Morrow used are currently or had been at Johns Hopkins in Baltimore. And when I walked into the room and I actually saw them, I cried because I'm a big HCM geek, and just what he was able to create and do and how many people have been helped from it is miraculous. He, however, was not a great patient, and he had atrial fibrillation and did not want to take Coumadin because he wouldn't be able to operate because he might bleed. And unfortunately, he suffered a stroke. So please take your anticoagulation if you have AFib and HCM, because we lost a great mind because they didn't do what they should have done, but it was the 80s and we didn't know as much. Okay, so Megan, I do not see Megan up here anywhere. Is that who we have coming up next? There she is. Megan, you want to open up your mic and share and tell us what we have in store?
Yeah.
It's that nice little screen share button.
Yep, I'm working on it.
We're going to get to your questions in just a few moments. So Megan, it's all on you, and we're going to discuss genetics and HCM.
Sounds good. Hi, everybody. I am happy to be here talking with you today. From the participant list, I know quite a few of you, but the other maybe half of you that I don't know, it's nice to see you here. I've been the genetic counselor for OHSU here in Portland for the last 6 years. As I think Ahmed had said earlier, as far as I know, I'm the only one that specializes in cardiology genetics in the state of Oregon. So I'm happy to be here today talking to you about one of my favorite topics. And whenever I talk to patients or when I'm scheduled to see them, the first question I always ask people is, what do you know about why you were sent to see me today? And the reason I always ask that first is because 9 times out of 10, the answer to that question is, I don't know. My doctor just told me to come. I don't know what genetic testing is. I don't know what genetic counseling is. So I really like to explain that my role within the HCM team is to help patients understand the hereditary nature of HCM and to help them understand how to use genetic testing information to best benefit them and their families in terms of making sure that we're keeping people safe. So today I'm going to talk to you a little bit about that. The big picture idea behind genes and genetics is that your DNA is your hereditary material. Little pieces of the DNA are called genes, and they produce proteins that act on the different systems of your body. There's thousands of different genes in our body playing thousands of different roles, and you have to have healthy functioning genes to have healthy functioning proteins in order for all the systems of your body to work the way that we expect them to work. In HCM, we're thinking about the genes that are supposed to be playing a role in how that heart muscle develops and how it's regulated. So there's lots of different genes that are playing small roles together to make sure that the muscle is the right thickness and has the right ability to contract and to pass the electrical rhythm of heart and all of those good things. And in patients that have HCM, what's going on is there's a defect in one of those genes. So there's sort of dysregulation of how the proteins are supposed to work that are supposed to be playing that role to regulate that heart muscle. So the muscle gets kind of big and thick, as we've kind of seen in some of the other presentations, related to how the genetic makeup is of one person versus another person. So when I'm talking to families about genetic testing or why do we offer genetic testing, the answer is sort of twofold. The first is to get a better understanding of the patient themselves and their heart. If we can pinpoint why somebody, what is that genetic risk factor? Why did somebody develop the HCM that they have? Gives us a better understanding of where that came from. At this point, we don't change much about healthcare recommendations for patients strictly on the basis of genetic testing info. So for the patient with HCM, we're really managing them according to what their heart looks like and how they're feeling, and the genetic testing doesn't necessarily weigh in on that. But the place that it is really useful information and that it does change things for families is for their family members. So if we're able to pinpoint why a patient with HCM developed the disease that they have, we can offer that same genetic test to relatives so that they can see whether they inherited that same risk factor and are also at risk to develop HCM. Those that did inherit that risk, we would want to keep a closer eye on them and their hearts. And then those that did not inherit that risk factor, we can provide some reassurance and say, hey, I know your relative has HCM and that it's a hereditary condition, but you yourself didn't inherit that risk factor, so you don't need to be worried about that. So those are the biggest places that we use this type of information currently. I know from the poll that about, over half of you have already had genetic testing, but for the 35% of you that haven't, in case you want to pursue it, I have some homework I can give you that would be really helpful to bring when you meet with me or with another genetic counselor in terms of your personal and your family history. So there's a lot of pieces of info that I always ask patients for to get a better understanding of what's going on in their family, because it can help dictate what is the best genetic test to order for somebody. So obviously we always ask if the patient or the family members have been diagnosed with HCM. We want to know about anybody who died suddenly or unexpectedly. If there was an autopsy, what did the autopsy say? We want to know about things like heart attack, cardiac arrest or stroke, heart failure, history of heart surgery, including heart transplant, whether anybody's had an ICD, the implantable cardioverter defibrillator, or whether anybody's had that implanted. And then if you can get ages at diagnosis and ages at which people passed away, that information can be helpful as well. We tend to see in genetic conditions that people are diagnosed at a younger than expected age compared to people who don't have genetic heart conditions. Oftentimes I get people asking about adoption and whether we can order genetic testing if people don't know their biological family, and the answer is yes. And then if anybody in the family has already tested positive and already has a known genetic cause for their heart condition, it's really helpful to get a copy of that test result, because I'll use that to make my best recommendations for other members of the family going forward. So once a genetic test is ordered, what are the possible test results? This is kind of a broad generality, but or generalization, but the main types of test results we can get are positive, negative, or inconclusive, or a variant of uncertain significance. And there's kind of this misnomer when people think about genetic testing, oftentimes they think of it as like a yes/no answer. I have this genetic disease or I don't have this genetic disease. And actually the way that we analyze genetic material, it's really a scale. So all of us have lots of different variation in our genetic material. That's why we have, different eye color, different hair color. All of those are examples of how my genetic material differs from Dr. Song's, for example. What we're looking at when we're looking at genetic testing is, do we have a lot of evidence about one specific change in your genetic material that says, yes, this is a defect to that gene that's causing HCM, or nope, this change in your genetic material is totally harmless. It doesn't have anything to do with a heart problem. And so when we're doing genetic testing, we're trying to weigh on a scale, like how much evidence do we have to say, yes, it is causing disease, or no, it's not. So then what does a positive genetic test result mean? It means that we've pinpointed the hereditary risk factor in your family. This can also be called a pathogenic variant or a likely pathogenic variant or a mutation. It goes by a lot of different names. But basically, it means we've identified why somebody developed HCM, and it gives us something that we can offer to other family members to test them for. We get a positive test result, depending on what study you look at, between 30 and 60% of the time. And that really allows other family members to get their own genetic testing so that, like I said before, the people that have that same risk factor can get appropriate healthcare to manage it. And then the people that didn't inherit that genetic risk factor don't need to be worried about it for them. And also they can't have passed it on to their kids, so it doesn't skip generations. A negative test result means that when we looked across all the different variation in your genetic material in the genes associated with HCM, we didn't find any changes that are known to cause HCM. This is also known as like no mutation found or no mutation identified. And it means we did not figure out a hereditary cause for your HCM. A negative result is not the same as saying that it's not genetic. We think all of HCM at this point has a hereditary basis. We just don't know all of the genes yet, so it's not a perfect test. We think that there's genes out there that we just haven't discovered yet, so we don't know how to test for them yet. So given that we can't completely eliminate all of the hereditary risk factors through the genetic testing that's available today, we do still want to manage family members as though under the assumption that they're at risk for HCM because of their family history. So for parents, children, and siblings of the person with HCM who had a negative genetic test result, those family members should continue to undergo cardiac screening for HCM. I also always recommend if you get a negative genetic test result, keep in touch with me over time because we do learn about new genes over time and you could be eligible for additional genetic testing in the future. And then the most commonly misinterpreted test result is an inconclusive test result or a variant of unknown or uncertain significance, a VUS. What a VUS means is that we don't have enough evidence about a specific change in genetic material to prove it causes HCM, but we don't have enough evidence yet to prove that it's totally harmless, totally unrelated to HCM. It's kind of this gray zone. And because we don't know one way or another what the significance is of that genetic change on health, we don't change healthcare recommendations on the basis of an inconclusive result. Instead, we have to keep researching that over time, and as we learn more about it, we can pass that information on to patients as we learn more. But while it's still sitting at that inconclusive stage, we don't generally recommend testing relatives for these inconclusive results because we wouldn't change their healthcare regardless of what their results are. And we would still recommend that parents, children, and siblings of the person with HCM continue to get their own screening. And I think, Dr. Balaji might be speaking to this a little bit more after this, but I wanted to briefly go over what type of heart screening is recommended. So as a general rule, the main types of screening that we do for people who are at risk to develop HCM are the echocardiogram, the ultrasound of the heart, and an EKG, the electrocardiogram, which is where they put the stickers across your chest and look at the electrical rhythm of the heart. When people are adults, we screen them every 3 to 5 years, assuming everything's looking good and they're not having any symptoms. Kids, we screen a little bit more frequently because they're growing so quickly and it's kind of a higher risk time point for them to develop HCM. So depending on specifics of the family history, we do that between every 1 and every 3 years. And if anybody has questions, you're welcome to contact me. If you are not in this area, I know there's a few of you on the call not from here, the National Society of Genetic Counselors has a website called nsgc.org. And right on that website, there's a button that says find a genetic counselor, and you can find somebody in your area.
Thank you, Megan. I think I got a mixed message, or I think Dr. Balaji was supposed to go first and then I screwed that up. So my apologies for the inconsistency there. So now we have to get Dr. Balaji to come back on screen with us. Ready to go. He's dozing. So while he's dozing, there he is. Okay. I will address 1 or 2 questions and then we'll get his talk going up. Alex wanted to know or confirm or state that he believes that there's an 85% chance of patients who undergo myectomies will survive till 10 years after surgery. Dr. Song, you want to reply to survival rate?
Sure. I think he was referring to the graph that I showed, which was from the early 2000s. I think just to clarify, that was a large group of patients that was very heterogeneous. It probably included young patients and old patients. So I think the expected survival after surgery kind of depends on mostly on how old a patient is and what other medical problems they have. Basically, we would expect a patient's life expectancy to be restored back to normal or near normal after successful surgery. Ahmed, do you want to comment on that?
Yeah, exactly. I agree. If you recall, I showed a figure I said from Dr. Marin's study. When you look at the rate of death or survival after any procedure, you need to compare it to the predicted or to the actual US population for age and sex matched. And so when you do that, after successful myectomies, typically patients have normal survival or normal lifespan as predicted.
We have some data that hopefully will get out later this year that through the HCMA population, the survival rate is damn close to 98.5% at probably 7 to 10 years out there. So it's a very good survival rate. Unfortunately, there's still a risk associated with any kind of surgery. So there's always going to be some risk there. Anne asked, what is the difference between genotype and phenotype? And Megan's unmuting her mic without even being asked.
Yeah, so genotype refers to your genetic test results, like your hereditary makeup. Genotype can tell you that you are at risk to develop HCM, but it doesn't actually guarantee that you will. Some patients that have the genetic risk factor don't ever go on to actually develop the disease. Phenotype, on the other hand, means that you physically have HCM. Your heart is affected by HCM. And not all patients that have the phenotype have a positive genetic test result, so it goes both ways.
One last question, and we're going to go to Dr. Balaji, and this is about rhythm management and atrial fibrillation. Are patients likely to be non-responders to ablations if they have HCM? And if somebody has had an unsuccessful ablation, is it worth trying a second attempt, or do they just give up? I don't see Dr. Nasser here, so I'm going to go to Ahmed and say it's on you.
Yeah, certainly. So it is dependent on the type of the arrhythmia. I see here the question says AVNRT, and that is HCM or no HCM. That is a bit different. And I actually just saw that Dr. Balaji is still with us too. He wasn't on my screen, so he can also answer this because he is the expert when it comes to these procedures. So I'll head it over to him.
Yeah, can you hear me?
We can hear you.
Yeah, so I think the question is it worth trying ablation again? So if you have HCM, as Dr. Nasser said, atrial fibrillation is the commonest arrhythmia in the planet, in human beings. And generally it's an arrhythmia of old age. I see Babak has come back on. Babak, this is a question of yours that I'm addressing, just in case. So atrial fibrillation develops at an earlier age in people with hypertrophic cardiomyopathy. And yes, there is some data that the results are a little worse in HCM patients compared to patients without HCM who have atrial fibrillation. But there's also data that shows that, sometimes even in completely normal patients without HCM, one go of ablation is not enough and you need to have more goes at it. So if you have had an ablation and you continue to have atrial fibrillation, certainly you should talk to Dr. Nasser or somebody like him and ask this question, and very likely the answer is going to be yes, we can have another go at it.
Okay, I'm going to hand the microphone over to you, and you can do a slide share, and we'll get your talk going. There's a couple of other questions here that we'll get to at the conclusion.
Okay, I hope everybody can see my slide.
Yeah.
So I'm going to be talking about HCM in children, and I am a pediatric electrophysiologist by training. And I got interested in HCM in a very roundabout way, which I will tell you the story. I'm also, just to promote pediatric electrophysiology and the role we play in HCM management, we have an organization called PACES, which stands for the Pediatric and Congenital Electrophysiology Society. So I'm actually currently the president of PACES for this this academic year. And this is an organization that is a very active organization taking care of kids with arrhythmias and with conditions that predispose them to sudden death, such as hypertrophic cardiomyopathy. So I got into HCM because about 15 years ago, we had a heart failure specialist. And one of the things that you might come across is in different institutions who takes care of kids with HCM varies from institution to institution. In some, it comes under the heart failure team. In a few, like us, it comes under the EP team. In a few, pretty much any cardiologist will take care of HCM patients. So it's really a mishmash, and there isn't much uniformity in the field as far as this is concerned. One of the nice things about OHSU and where I practice, which is this great team, and having all these resources like Dr. Masri, like Megan, like Dr. Song, like Dr. Nazar, we work pretty closely together. And if there's any question about any patient, we are constantly emailing or texting each other, talking about it. And I personally have benefited hugely from this. Particularly, I want to call out Megan and how closely Megan and I work and how much she has helped me in taking care of my patients with HCM. So 15 years ago, we had a heart failure specialist who was taking care of patients with cardiomyopathy, including HCM. And he got a job elsewhere to head up a heart failure transplant program at a bigger center. And as he was heading out the door, he needed people to take care of his patients. And he walked into my office and said, "Hey, Balaji, you've seen every one of my HCM patients because I've invariably asked you the question, whether there's an electrophysiologic problem, are they at risk of sudden death, etc. And so they all know you. Is it okay if you take over these patients?" And it was a moment of weakness. I confess, I said, sure, without really understanding what I'm getting into. And as I started seeing these patients, I realized really I have this huge knowledge gap in HCM. And so I started reading about it. I went to courses and so on. And this really got me interested, and so much so that this has become one of the main focus of my academic career and my research. I think Dr. Masri and even Lisa mentioned this paper that just came out, the big guidelines on hypertrophic cardiomyopathy. There really isn't much about children in this. We will talk about it a little bit as we go along, but just to go back, we have this full capability of this team that you've all pretty much come across now during these talks. And so it helps me to go last. The one thing I do want to mention is that, not just the fact that we have great imaging capability, our pediatric echo lab, for instance, is awesome. We have some of the best echo people I would say, in the country when it comes to diagnosing and characterizing HCM. We have a fantastic MRI team. I work very closely with them. We have fantastic CT for those who cannot get an MRI. You already met Dr. Masri and Megan and Dr. Song. We do transplantation in teens, but we don't do transplantation in smaller children. But we work very closely with the Seattle transplantation team, and we work very closely with the Stanford transplantation team for those patients who need it. Luckily, this is a very, very tiny few patients. So HCM in infants, we do see HCM in very small babies, even in newborns, and in the first year of life. This is extremely, extremely rare. We have to exclude pseudo HCM due to mothers having diabetes and the heart being thick because of that, because that is usually a finding that resolves with time. In the rest of the patients, there's a very high incidence of multi-system disease, either genetic syndromes like Noonan's, inborn errors of metabolism like Pompe's, and other storage disorders, and other multi-system disorders. Idiopathic, and what we are been talking about all this time, which is what we now call sarcomeric HCM, is due to certain mutations, etc., and not associated with other conditions, does happen in infants, but it's very, very rare. And in infants, the results in the outcomes, the mortality, etc., is supposed to be a little higher, and really depends on the other problems that they have, such as the metabolic diseases and so forth. Once we get into older children, and particularly teenagers, we are mostly dealing with the same kind of condition that we are dealing with in older people. They do have a better prognosis than infants, but here we have this higher risk of sudden death. So there have been many papers, including particularly Dr. Marin, who's studied this extensively, as you all know, showing that the younger you are, if you're a teenager or a young adult, the method by which people come to mortality and death is sudden death. So this becomes a more important problem. However, as I will show you, this is a poorly studied group. And some of the earlier speakers mentioned this, especially Lisa. This is we have had patients present literally from all the way from sudden death or from which they've been successfully resuscitated to incidental findings because of either a heart murmur or somebody did an ECG for some other reason. They were worried about something else, and hey presto, this patient has something that suggests hypertrophic cardiomyopathy, and then we've evaluated. So also keep in mind that the ECG, and we have some actual research that we are publishing shortly, can be completely normal in patients with hypertrophic cardiomyopathy. Especially if you have a mild disease or early HCM, the ECG may not yet be abnormal, and therefore relying on the ECG as a screening test is probably not a great idea. If you're really worried about HCM, you should ask for an echocardiogram. That is probably the test that can help diagnose this. Megan just mentioned this. We do see a lot of patients who come to me through Megan because of a gene test that has proved positive. And then we check for the phenotype, which means we check the echo to see if there is thickening or not. We see the patients as soon as this suspicion has been raised. Even if it's an infant, there is no age, families have lots of questions, and my job is to address their questions and give them a framework of what to expect going forward. So I see them at any age. And then previously our approach has been to see them then, if they don't have any hypertrophy, to see them at age 7, then starting from age 10 every year until they turn 18. And if they are still negative, I pass them on to Dr. Masri and his team to be seen every 3 to 5 years. The recent guidelines, and this is what Megan was alluding to, says patients should be seen every 2 to 3 years, even if they don't have hypertrophic cardiomyopathy. So this is a change that we are coming to going forward. Now, the other question that always gets asked to me is, what about exercise? Or should we be restricting my child or not? This is a poorly understood problem. There's lots of research going on. Particularly this, some of you are probably participating in the LIVE or LIVE HCM project that coordinated out of Yale by Dr. Rachel Lampert. And we are hoping that'll help us a lot. It's very important to avoid obesity in children with HCM. We think obesity is a bad prognostic factor. It probably adds to the hypertrophy and so forth. So therefore, having the ability to do some moderate exercise, encouraging the children to be active and avoid obesity is very important. We think that if they have phenotypic HCM, currently the guideline says to avoid competitive sports, especially the high intensity sports where risk does go up. If they're only gene positive and they don't have the phenotype, they're okay to do all sports. One of the things I tell families is that if you have a child with a gene positive who is likely to develop HCM, given the family history, given the gene, etc., I tell the families to steer them a little bit away from focusing very much on competitive athletics, because I don't want to come back 5 years later down the line and say, sorry, you can't do what you have really trained to do and what you've set your heart on. And I don't like to break children's hearts that way. I've had children sitting in my office crying because I've said this to them. And it's an opportunity, if you know already that your child is likely to be very athletic, to steer them a little away. Maybe tell them to take up golf, maybe tell them to take up tennis, sports that can be played at lower intensity. As some of you know, the bad outcomes often happen with basketball, happen with football, with soccer and sports like that, and don't seem to happen with some of these low intensity sports like golf and tennis. We discourage them from doing any weightlifting, especially lifting weights that makes the children have to hold their breath when they're lifting. Lifting light weights where it doesn't interfere with your breathing is completely fine. And we also emphasize the importance of AEDs during sports. I talk to the families extensively about the possibility of having an AED, see whether it's something that they are open to having. And if at all possible, I encourage them to try and get an AED at least during sports when the children should be in school or in the practice grounds. And if the family is open to having an AED in the home, I completely. Now, we've talked a little bit about sudden death. We frequently get questions about sudden death, and there is poor literature guideline in children and teenagers with HCM. Conventionally, until about a few years back, there were lots of adult papers with large populations which had been studied both in the USA mainly by Dr. Marin and his colleagues, in England by Dr. Elliott, by Perry Elliott and his colleagues, and in Italy, the Italians have been very active in this, and there have been lots of papers. In children, the pediatric cardiomyopathy registry collected a lot of data, but mainly their patients were less than 10 years of age. And so there was really a gap in the literature between the age of 10 and 20 years of age, which we are really filling. I'll come to that in just a second. The other question that gets asked is, does my child need a defibrillator? And if my child needs a defibrillator, can they get a defibrillator? These are all patients of mine with defibrillators, starting from a 3-month-old with a defibrillator, a 5-year-old. This child actually did not have hypertrophic cardiomyopathy. This 5-year-old did have hypertrophic cardiomyopathy, and we put a defibrillator in. This is what is called an epicardial defibrillator. The lead goes behind the heart. It is done with the help of surgeons, and the actual defibrillator sits in the belly area. This is a conventional transvenous defibrillator that I put in many years back in an older child, age 7, who was a decent size. And this is a 14-year-old with a subcutaneous defibrillator, which again, Dr. Nazar showed earlier on. So the point I want to make is defibrillators can be implanted at almost any age. And because sudden death can be the first event in some patients, it is our job as electrophysiologists to really put patients through a battery of tests to decide whether they need what is called a primary prevention defibrillator. This is very important. And this whole issue of risk stratification is what we've been talking about a lot in the last few years. Dr. Nazar already showed this slide from the European Society where you can punch in some numbers and it throws out a risk within the next 5 years of having a sudden death-like event, but it clearly states that this is not applicable to children less than 16 years of age. This is a study that I am proud to say that I participated in and actually coordinated through PACES. We collected a lot of data using 35 centers on a lot of children with defibrillators, and we just published this in Heart Rhythm last year or 2 years ago. And this is one of the studies that showed that the risk factors in children are very different to those in adults. There have been subsequent studies, especially a study from Italy, that confirmed this finding. And now we've moved past this very quickly. There is a lot of interest in this field. This is a study coordinated by my good friend, Dr. Juan Kasky from Great Ormond Street in London. And he put together a huge cohort of over 1,000 patients looking for a model to try and predict it. And yes, eventually the idea is we will have this something similar to what the adults have. It'll be on the web. We can go in, punch in numbers and get a pretty reliable estimate of what the risk for sudden death is. And this is an excellent study that showed that for every 10 defibrillators implanted in patients with a risk estimated of greater than 6%, there was one potential save in that group. Another study which we also participated, was coordinated out of Toronto with sick children in Toronto by Dr. Mittal and her colleagues. This just came out, 570 patients, another risk prediction model. And so these studies, basically what I want to emphasize to you, that there is a lot of energy in the pediatric community in trying to predict risk for children with HCM. And I think we are getting much better. I'm very hopeful in the next few years, very shortly, I would say in the next year or two, we are going to have a risk prediction model published online and which can be used online. Other things that I want to stress. If there is any sudden death or sudden cardiac arrest in a young person, that person deserves an autopsy. We conventionally say anybody dying suddenly less than 35. There needs to be an autopsy. It's very important for everybody in the community to stop using the word massive heart attack, because that implies that there is some kind of a coronary artery problem, which may not necessarily be true. It's important to use the word cardiac arrest so that an autopsy gets done. Conditions like hypertrophic cardiomyopathy in the index case can then save their kids, save their siblings, and save other family members. And I always emphasize, never let a sudden death or a sudden cardiac arrest go in vain. It's very important for the family to test other people and do what we now call cascade screening. So I'm going to conclude. Infants with HCM often have other issues and have to be looked at very closely for other syndromes or other conditions. Sarcomeric HCM is more in older children, and cascade screening definitely saves lives. Sudden death is a rare risk in older children with sarcomeric HCM, and risk factors are different in children and teens. Common adult risk factors are not predictive in children, and there has been huge progress in the past 2 years. We are also collaborating with the Toronto group to participate in this international registry. And I'm happy to say I also have some grant funding to look at risk factors for arrhythmias in children with primary prevention ICDs, and this is a PACES study. You may say that I haven't touched much upon obstructive hypertrophic cardiomyopathy and myectomy in children. We treat them very similar to what adults, the way adults are treated. It's mostly a problem of teenagers. Having Dr. Song and Dr. Shen, who's my colleague, Dr. Song's counterpart in the pediatric world, they work together, and they've certainly done myectomies with great results on a number of children in our patient group. And one of the interesting things that we found in some of these studies that we've recently published is that having obstructive hypertrophic cardiomyopathy those patients seem to be at slightly lower risk of sudden death and seem to have a lower risk of needing defibrillators, which is a very interesting finding that has been coming out in the last couple of years. We don't know why this is, and more studies are needed to understand this. This is my daughter. She's no longer that little. She's actually going off to college this year. But back to basics. Children are not little adults. They need special care. They need to be treated in specialized centers focused on children with hypertrophic cardiomyopathy. With that, I will stop sharing. Thank you. And I'm happy to take any questions from you.
Thank you so much. If we can get our faculty back up here, we have a couple of questions that we're going to handle while we're still streaming on Facebook. And then we're going to go offline on Facebook and turn off recording and answer any questions that our Zoom participants would like to hear in private or discuss without being on the internet. So a couple of like random questions here. How long do you think it will be, or will it ever be, a standard therapy utilizing ultrasound ablation instead of a surgical myectomy?
Yeah, great question. There's several steps that we are in the process of undergoing. So we've had our initial meeting with the FDA. It's probably going to take about 2 years of validating our electronics. You know, we build these by hand in our lab on a bench top, and we do a pretty good job, but it's going to take partnership with a larger company to get them built in a clean room and with all the electronic testing. So if I had to guess, I would say 2025 before we're able to be, you know, starting human studies and doing it more broadly.
Thank you for that. Pediatric questions. I'm going to double these ones up. Number one, do we use different ICDs for children? Are they smaller? And do you have any tips for help motivating a teen to lose weight? And how do we balance that body image issue with boys and girls and deal with the weight issues in a safe manner for them physically and emotionally? You're on mute. Balaji, you're on mute.
Sorry. Yeah, great questions. Yes, the ICDs are generally the same as for adults. There is a smaller ICD with a lower battery life, lasts probably somewhere around 5 to 7 years, which has a smaller battery. The smallest size that I know of is about 28 cc's. And like I showed, we've been successful. Actually, that infant that I showed you, the 3-month-old that we put an ICD in, that was done about 18 years ago. So ICD technology in terms of size hasn't gone down that much in almost 20 years, mainly because battery technology has remained fairly stable. It's gotten a little bit smaller because the circuits, the computer part of it has gotten tinier, the chips have gotten smaller, but the batteries are still fairly the same size. The subcutaneous ICD is something that's the newer one on the block. Dr. Nazar showed you that. It's really not very suitable for small children because of its size. It's really a huge box. And when it has been put in very small children, there's been skin erosion and problems with the skin breakdown. So it's not very suitable for small children. Our hope is that that'll also get smaller with time, because that is a huge advance for many of these patients who don't need a pacemaker. It avoids going into the heart, et cetera, et cetera. And I'm very hopeful that that'll get smaller with time. As far as the weight loss, that is a huge problem. I don't think I can answer that question satisfactorily. I agree there is a body image issue. We don't want them to feel that it's something that we don't want to beat them up about it, but it's a medical issue. From a medical standpoint, obesity is certainly a problem. So we have to emphasize that it's not about beauty and about body image, but it's about health and maintaining health. And therefore we need to encourage them as them taking responsibility for their health and doing their part to stay more healthy with HCM for longer periods of time. And involving a dietitian, involving a psychologist. We haven't talked about psychologists in this meeting so far. One of the nice things we have at OHSU is I work with a great pediatric psychology team. I work with a great pediatric psychiatry team. And we also have somebody who's very special in the adult world, and she takes care of some of our teenagers who have psychological issues. Her name is Adrienne, and Adrienne is a huge person in our group. And hopefully, if you have any questions, if you have a child, especially if you have a teenager, but maybe not a very small child with HCM, we certainly involve Adrienne in the care, and she can help a huge amount with the psychological aspects. Children have difficulty coping with the issues of mortality. When we put a defibrillator in a child, that is a huge step. I mean, at that age, they really don't have the resources. They don't have the mental makeup, the emotional makeup to deal with what's being put in front of them, which is the fact that they could die suddenly. And we have to involve psychology. We have to involve psychiatry to help them deal with it. And it's not just the child, the whole family needs help. It's a huge, huge topic that, we've literally just scratched the surface of.
We are actually working on a symposium specifically on this topic, and to drive the point home a little bit further that we need to engage our mental health professionals in this fight as well. I was a 12-year-old child once, and that is when they told me I had HCM, IHSS. And in that same conversation, which was about a 20-minute conversation, I was told I could die suddenly and there's nothing anybody could do to save me. I was 12 years old and I got a pat on the back and out the door I went. My question to the doctor was, well, do I have to do my homework? I'm going to die, aren't I? So homework was optional for a little while there for me. I eventually figured out that I was going to live, so it was easier doing the homework than getting yelled at all the time. But that was probably not the most healthy way I could have dealt with that whole situation. So I encourage you as parents to get mental health services involved for your children if it's necessary. Some of them do really well and they're quite, resilient in their diagnosis and how it's handled with them. But don't assume it's okay. You probably want to assume to the other side that you need a little bit of help there. We're all processing a form of grief when we're diagnosed. Now imagine a child trying to process those same life-threatening mortality issues. It can get a bit intense for them. So please, we were going to continue that conversation. And I look forward to, hopefully putting together a nice symposium for the fall on the mental health needs of the community and tying in anybody from your staff that might be interested in helping in that project.
Well,
Thanks, Lisa. I'd
Dr.
like to,
Naz has just put this on the chat, Adrian Kovacs, and he's given the contact.
Yeah, thanks, Balaji, for bringing up Adrian. She's a huge asset to our program, both in HCM and beyond. You know, shortly after I joined the faculty here, I started taking care of a lot of the patients, HCM and non-HCM, who have ICDs and receive shocks. And, you know, while we don't think our patients necessarily have psychological diseases, we all have psychosocial symptoms to some extent. And the ICDs bring that, you know, both the body image issues of having them, the uncertainty of when they may go off. And so Adrian and I co-founded a multidisciplinary ventricular arrhythmia program, the link of which I pasted down there. It's not HCM specific, but many of our HCM patients are in it. And we see patients together. At the first visit, they see me and Adrian. They see our device nurses to check their device. And if they have HCM, they see Dr. Masri and Megan. If they have another kind of cardiac condition, they see the relevant cardiologist for that. And it's interesting, you know, going forward, some of them decide that they really need to see her more frequently. Their cardiac issues are doing okay. They see me annually and they see her every month. Other folks are actually doing relatively well from a psychosocial perspective and see her annually and see me every month. And so we're finding that having us both available at the first visit and then going from there is really helping. The link is there.
Ah, a team approach. How novel. We love that. Thank you for that. And thank you for recognizing that there is a significant mental health burden in this community. You're going to hear us talking a lot more about that in the coming months and years. If you were diagnosed, and we do not wish this diagnosis upon anybody, if you're diagnosed with cancer or a systemic disease, they often will bring in a lot of psychosocial support groups, which we're now offering online. Or they'll offer you meditation or biofeedback or massage therapy, lots of different feel-good things, but they're all meant to calm the soul and to focus you on what's really important and help you manage your stress related to your diagnosis. And we're hoping to develop some more programs in that area coming up, so please do stay tuned. Question about conversion from SICD to a traditional transvenous ICD. What are we seeing now? SICDs have not been around quite as long. I know of a few that have been changed out for transvenous devices. How common is that? And please, one other additional footnote on that. There is now a recall on one of the SICD leads. Let's address that as well, please.
Sounds good, Balaji. I'll start and then you can chime in. So having to revise the device for either inappropriate shocks by doing some software reprogramming or maybe moving the leads, that's fairly common. That's probably between 5 to 10%. Having to fully remove the device and put in a transvenous device is closer to about in the 2 to 5% range. And the reasons for that, the most common reason is a patient going on to need pacing. Right. One of the major downsides of the subcutaneous device is it is a defibrillator, but it's not a pacemaker because it's not touching the heart. It can't pace the heart and raise the heart rate for patients who need pacing for slow heart rhythms. That's the most common reason, and that has happened to a few patients in our group. But it is quite rare to have to switch out to a transvenous. Balaji, any other of your cases?
No, I think you covered it. It's very important that the patients when the first consideration of a defibrillator comes in, that they be evaluated very thoroughly, and we do a huge evaluation to see if they are suitable for an SICD. If there is any question in our mind that they are not likely to be suitable for an SICD, we go straight to the conventional transvenous ICD, mainly because there's less experience. The batteries last shorter period of time, and there is this concern about inappropriate shocks. So we want to make sure with a very thorough evaluation whether they are suitable for an SICD. And touch wood, so far we haven't had any that in a pediatric age that we've had to do these changes. I've done about somewhere between 5 and 10 SICDs, and so far they're all doing great.
Yeah, we do a very elaborate pre-implantation screening at our center, much more than the manufacturer recommends. It involves exercise. It involves exercise in multiple body positions. And so we really try to weed out the inappropriate shock patients so we don't put them through the subcutaneous and have to then change it out. And with that more elaborate pre-implantation screening, we've gotten those rates down. The next thing we do is 1 month after implant, once the subcutaneous defibrillator is really sort of settled into where it's going to settle, we bring the patients back, we exercise them again in clinic, and we have the device take a snapshot of what it's seeing when they're exercising, because many of the inappropriate shocks happen with exercise. And so we tell the device, hey, this is what exercise looks like. If you see this, this is not something you should shock. And that's helped us get those rates down as well. You brought up the recall, Lisa. So that's a great point. It's making a lot of news. There's a recall on one of the leads, and there's a recall on one of the batteries as well. It's making a lot of news because
we're talking about Boston Scientific, SICD, and SICD lead, correct?
That's correct. So Boston Scientific is the only company that makes a subcutaneous ICD or a lead. And it's making news largely because it's the first recall on this type of device. It should be known that there have been many recalls on transvenous devices over many years. The rate of failure of the lead is about 0.2% per year. So 1 in 500 patients will have an issue with the lead. Doesn't mean 1 in 500 will be harmed. It's probably about 1 in 10,000 who may be harmed. And then as far as the battery, it's about 0.4% per year. So about 1 in 250 patients who will have a battery problem that really the battery just drains faster than it should. Things for those of you who have subcutaneous ICDs or may be interested in getting one to know is the response is not to take these out right away. That is not what's recommended by the FDA, the manufacturer, or by us, but you should be aware of it. The devices have audible tones. They will beep at you if one of these issues pop up. So the immediate response is to get in touch with your providers. We have a system where we're bringing all of our subcutaneous ICD patients in for a sit down in clinic. We're showing them what the beep sounds like. We're making it beep at them. So it's important you know what kind of beep it is. It's not a truck backing up in your driveway. And that you're established with remote monitoring. That your bedside monitor is connected to your device, that your bedside monitor is connected to your electrophysiologist device clinic, because not only will it beep at you, but it will beep, quote unquote, at us as well. And then we can bring you in to do what's necessary. But these rates are low enough and frankly below the rates of transvenous device recalls that have happened in the recent past that we're not empirically taking these out, nor are we stopping and planting new ones because there are still a lot of benefits. I should say, I have no conflict of interest with the Boston Scientific. I don't receive any grant or consulting fees.
Okay, we're going to stay on ICDs for a minute, and there's a couple other things we're going to address. So there's been some brouhaha in the popular media about Apple phones and devices having this interaction, and you can turn off your device. Now, if people have actually read the little booklet that comes with their devices, it tells you to keep your iPhone a certain distance away from the device. So can we all agree that this isn't really new information? It's just a new study that said, look, we actually did it.
Go ahead, Balaji. Do you want to take this one?
Yeah, I mean, this is something we've known about for decades. If you have a defibrillator in your left shoulder, don't hold your cell phone on your left ear. Hold it on your right ear. Have at least 6 inches of separation between the cell phone and your device. Or better still, keep it in your hand and have earphones. This has been well known, and yeah, I completely agree with you, Lisa.
Yeah, it's not really even major studies. These are 2 case studies, 2 sort of individual cases. In both situations, the iPhone 12 was placed directly over the defibrillator. And so it's just important to not do that. Yeah.
Doc, it hurts when I do this. Don't do this. That would make sense. Going into your beeping question, yours truly was at a wedding way back a couple of years ago. Happened to be Marty Maron's wedding in Boston. And the next morning I woke up and I'm like, my stupid smoke detector from my house must be in my suitcase because that beeping followed me to Boston. At which point I went, oh my God, it's my device. So I called Mark Link the day after the wedding. We're all feeling a little worse for wear. Like, can I meet you at the clinic? I think I'm beeping. And that was my last battery replacement. So I can tell you when Marty and Mary got married by the dates of my devices.
It's Marty's fault.
I blame Marty for everything. I'll just blame him. It's all his fault. So that was my funny beeping story. So you really should remind yourself every once in a while what your beep sounds like. And no, it's not necessarily, especially when it's always at 9 a.m. in the morning and you just think your smoke detector is going off every morning at 9 a.m. And by the time you get there, it stops beeping. I really had a lot of,
the most important reason it beeps is that your battery is down to the last, almost depleted. So the most important thing is if it beeps, don't ignore the beep. Call your physician or send in a remote transmission so that they can look at what the device is, the device is collecting information all the time. And that information can be downloaded, we can look at it, and then we can act on it.
Okay, I'm going to say goodbye to our friends on Facebook, and I'm going to turn off the recording feature. For anybody on Facebook who's watching right now, you can sign up for future Bighearted Warrior Tour and join us in the Zoom room and ask your questions. We'll be back with another event exactly a month from today, March 11th, when we will be meeting with the team from Emory. So you can come back and join us to hear some other perspectives on HCM. So sign up. All of our events are free thanks to our sponsors. And again, thank you to them, to Bristol Myers Squibb, Cytokinetics, Boston Scientific, and Invitae for being our partners in this endeavor. So goodbye, Facebook, for now. Stop streaming. And you're all going to hear that we're stopping recording.